my respected professor, Dr. Bishoy sir, and my fellow batchmates. I am Biraj Sarkar. This is my team, Brijesh Kumar Das, Devasmita Roy, Chandan Bhattacharya, and Devashish Mahato. Today, we will discuss the topic of gene regulation in eukaryotes. Introduction. Every single cell in human body have the exact same instruction manual. Like this is the ultimate paradox of biology. If we pull a DNA from a retina cell and a liver cell, they have the exact same blueprint. But unsurprisingly, the liver cell doesn't detect light and the eye cell doesn't produce bile. So how this happens? We will discuss it today. So before gene expression, what is gene? Gene is a sequence of DNA or RNA which help to synthesize protein. Gene expression. Gene expression is the process by which the information encoded in gene is turned into a function. This mostly occurs via the transcription of RNA molecule. So now the concept of on-off switch. Like if we take the example of insulin gene, when we talk about the concept of on-off switch, we talk it like a binary system, and sometimes actually they are. Like if we take the example of insulin gene, it's exclusively get turned on the beta cell of pancreas. And there are some other genes like beta-actin, which is also known as a housekeeping gene. Those genes act in the background all the time. So regulation of gene expression, the process used to control the timing, location, and volume in which they are expressed. This process can be complicated and carried out by variety of mechanisms, including regulatory protein and chemical modification of DNA and RNA. So why do we need gene regulation? First is ontogenesis, that is development. From the fetal stage to adult stage, we constantly need gene regulation. Like if we take the example of growth hormone, in puberty stage it is expressed highly, but after the adult stage it is not expressed as much. Next is differentiation. Without differentiation, there will be a major clump of cell. Next is adaptation. In harsh condition and against deadly pathogens, we need adaptation for the gene regulation. And finally, dysregulation of gene may lead to genetic disorders. So now the difference. So when we talk about gene regulation, first we have to talk about the prokaryotic gene regulation. The prokaryotic gene regulation is highly simple. It's all occur at one compartment, that is called as nucleus. So it is called as coupled process. But in our case, that is in eukaryotes, the transcription occurs in the nucleus, and then the transcribed messenger RNA have to be transported out of the nucleus to the cytoplasm to get translated into protein. And the prokaryotic regulation may mainly occur by the lack of operon, which we completely lack. But in case of chromatin structure, our DNA is extensively folded and wrapped around a structural protein called histone. But prokaryotes completely lack them. So, in prokaryotes, gene regulation is highly simple, time efficient, but in our case, it is very time consuming and complex. It may seem as a downgrade, but we will discuss why it happens. So now, my colleague will proceed.
Thank you, Virat. My name is Brijesh Kumar Das. I am roll number 32. I will be going to continue from here. So our next topic is mechanism of gene expression. Before we deep dive into mechanism, we must know what are the levels of regulation. Here in this flow chart, we can see that there are five levels where gene expression is controlled. At DNA level, it's called epigenetic control. At transcription level, it's called transcriptional control. At mRNA level, it's called post-transcriptional control. At translational level, it's called translational control. And at last, at protein level, it's called post-translational control. So, our next topic is DNA level control. In which first topic is gene amplification. Gene amplification simply means increasing the number of genes. It is activated when the requirement of gene product increases rapidly due to some external stress. Second point, it's generated by repeated initiation of replication, and it has an unfortunate side effect seen in cancer patients which undergo long-term methotrexate medication. We see that in those patients, DHFR, which means dihydrofolate reductase gene amplifies, uh, which leads to methotrexate resistance, uh, which leads to methotrexate resistance. And even after giving medication, the cancer cells proliferates. Our next topic is gene switching. Gene switching means turning on and off gene when required by your body. It can be seen in B cells. We see that during first immunological response, IgM increases rapidly, but during second immunological response, B cell switches from producing IgM to IgG. Our second example is different globulin chains in fetal and adult human. We see that in this graph we can see that before birth gamma globulin chains are more in number, whereas beta are less. But after birth we see that gamma decreases and beta increases. Our next topic is epigenetic control. Since epigenetic control is very vast topic, we are going to discuss it very briefly. What do we mean by epigenetic? Epigenetic, we see that epigenetic is made up of two words, epi and genetic, which means above gene. We made, we change the gene expression without changing the underlying gene sequence. It can sometime be passed on to next generation and may or may not be expressed. Our next topic is DNA methylation. DNA methylation means adding methyl group to gene sequences, specifically in cytosine and guanine rich regions. In this diagram, we can see that methyl group is added to cytosine. It typically represses gene transcription. With that, I conclude my part, and now it will be continued by my colleague Devasmita.
My name is Devasmita Rai and my roll number is 35. My topic is histone methylation or chromatin remodeling. Histone methylation is an epigenetic modification in which methyl groups are added to specific amino acids such as lysine and arginine on histone proteins. Histones are proteins around which DNA wraps to form chromatin. It also causes reversible transcriptional suppression but can also cause activation depending on the location of the methyl groups to which they are attached. Lysine and arginine residues are methylated, such as example, trimethylation of 9th lysine residue on H3 histone protein octamer causes silencing of the gene, and trimethylation of 4th lysine residue on H3 histone protein octamer causes activation of the gene. It plays a major role in aging, carcinogenesis, X chromosome inactivation, lionization, intellectual disability. Next topic is histone acetylation and deacetylation. In histone acetylation, removal of histone positive charge which leads to relaxed DNA coiling and there is more transcription. As heterochromatin is converted to euchromatin and euchromatin is transcriptionally more active. Example, thyroid hormone synthesis may be altered by acetylation of thyroid hormone receptors. Next topic is histone deacetylation, in which removal of acetyl groups leads to tightened DNA binding, which causes less transcription. Example, histone deacetylation causes altered gene expression in Huntington disease. Next topic is transcriptional control. As we all know, gene expression can be transcriptionally controlled by regulatory or transactin proteins. It control various biological functions including gene expression, cell signaling, and other metabolic pathways, transcription factors, activators and repressors, signal molecules and messengers. Promoter is the region in the DNA where RNA polymerase II and transcription factors bind. Promoters initiate the process of transcription. Then the hormone response elements formed from hormonal action on cell joins to enhancer region as either activators or repressor. Locus control regions controlled by DNA elements. Enhancers, activators influence the promoters to gene expression, and silencers, repressors, the repressor decreases the expression of gene. As we all can see here that there are two activators and one repressor binding sites on DNA. This gene is only expressed when both the activators are present and the repressor is absent. When both the activators are binded and repressor is absent, transcription happens. Only one activator is binded, then little transcription causes, and when all three are binded, two activators and one repressors, it inhibits transcription. Thank you.
Myself Chandan Bhattacharya, roll number 33. So, specific motifs of regulatory proteins: the helix, turn helix, zinc finger, and the leucine zipper. So first we explain the helix turn helix. Helix turn helix is basically formed by 3 helix and 3 beta sheet. The 3 helix have 3 roles. The first helix for the shape and the structure, and the second for the recognition site, and the third for the major group formation where the DNA binds. And next we then the zinc finger. The zinc finger here the zinc 2 plus ion as a finger and form the loop where the DNA bind. It has more as a role in the clinics, like the single A mutation in either in 2 gene finger, the calcitriol receptor to be mutated, then resistance occur to vitamin D and it is forming the rickets. It is more common in the child nowadays. And next, the leucine zipper. Leucine is an amino acid and which occurs and reduces at every 7th position, which is periodically controlled. And next, it is the 8 helical turn and 4 repeats, which is more crucial because in this point the mutation occurs regularly and enhance the association to separate DNA binding domains with their target binding site binds to major group of DNA. Major group of DNA and minor group of DNA. That's 2 DNA type. Major group is more recognized because the range is wider for binding of DNA, and the opposite side minor DNA group is narrower. Here is fluidly, tightly and possible, but it is quite difficult to the bind of the DNA. And the zinc ions, the finger-like structure forms the loop, and which is the zinc finger structure forming here for the DNA binding. And helix turn helix is a helical structure like the spiral structure it forms. And after the forming the spiral structure, the bending of the 2 protein bands. And then the leucine zipper, leucine the amino acid who is forming the zipper where the ultimately major group formation and DNA binds. But ultimate the function is, the whole function is to DNA motifs is to binding the DNA or sometimes RNA. The post-transcriptional control is the one of the most crucial control in regulation of gene expression in eukaryotes. The mRNA stability regulation, mRNA, which is in the cytoplasm. The cytoplasm, the mRNA, the stability of mRNA in the cytoplasm more, the protein synthesis is more. So the half-life, here the half-life is the 50% mRNA which is degraded. It's called the half-life here. The half-life is less, protein synthesis less, half-life more, protein synthesis more. The stability controlled by some factors in mRNA. First of is the 5 capping. Methyl guanosine triphosphate is the 5' end binding. By binding, it's prevent the exonuclease activity and prevent the translation process. And the poly-A tail which occur in the 3' end and the UTR. Here is the 2 untranslated region, 5' and 3' both. But the ultimate role of this 5 capping, poly-A tail and UTR is to prevent translation. And the 5 capping,
Poly-A tail specifically also prevent the exonuclease activity. The miRNA, microRNA, which is 18 to 25 nucleotides. But in 18 to 25 nucleotides, 2 to 8 nucleotides, the seed sequence because is basically binding with mRNA. And the 30% of human genes are thought to be the targeted miRNAs is also a crucial role, and so the miRNA can act as epigenetic modulators, which is previously explained by our colleagues. And then the miRNA, how miRNA is formed? miRNA is formed in cytoplasm, the primary miRNA. And primary miRNA through DOSA formation, which is enzyme. Then the pmiRNA means precursor miRNA. After the exporting 5 channel is outward in the cytoplasm, and the precursor miRNA then dicer, his enzyme cuts, and then the miRNA duplex, mature miRNA forms. But miRNA forms, miRNA but not able to bind the 3' end of the mRNA to prevent the translation. Here requires a complex which is RISC, RNA induced silencing complex, which bind with miRNA. Then the miRNA plus RISC go to the 3' end of the UTR untranslated region of mRNA to prevent the translation. RNA editing. What is RNA editing? RNA editing basically the change of the nucleotide sequence after the transcription. So it is the classical example of the apolipoprotein 100. Apolipoprotein B100 is normally synthesized in our liver, but it converts into apolipoprotein B48 in intestine. Intestine is the classical example CAA, the glutamine, which is formed into UAA, which is a terminal codon. We know it is stop codon.
Very well.
And form the terminal and the prevent the translation process by this. Is a classical example, and this sometimes the alternate RNA processing here, the alternate transcription start sites, because the start sites sometimes difference. To difference the mRNA the mRNA forming the different proteins, and then the exon that we see the alternate transcription sites.
Stop codon. Now stop codon. Emergency stop codon.
Thank you.
Thank you very much, Chandan. Now I'll be continuing from here. My name is Deficiency, roll number 34. Now basically we come to the last topic, translational and post-transcriptional control. Now translation control. You already know what translation is. Several different factors are required for translation. We have initiation factors, we have elongation factors, we have releasing factors. Now basically if we make modifications to these factors, it will change the underlying process of the translation. One example of this you can find in eukaryotic initiation factor to phosphorylation. Basically, we have eukaryotic initiation factor. Now, due to several stress, viral infection, or lack of amino acid, it may result in a cascade pathway, which will result in formation of protein kinase, which will phosphorylate the eukaryotic initiation factor 2, and as a result the 43 ribosomal pre-initiation complex cannot form, and if pre-initiation complex cannot form, then initiation of translation cannot occur, and if a translation is not initiated, then protein cannot be formed, and as a result the genome can be regulated. Now next we come down to a post-translational modification. We all know after a polypeptide chain is formed after translation, it needs to undergo process of post-translation. Here many different processes occur: cleavage, hydroxylation, phosphorylation, methylation, acetylation, glycosylation. If it does not happen, then an active protein cannot be formed, and as a result, it cannot work properly. Now, if there are mutations, it will of course lead to a change in. It will of course lead to change in the function of protein itself. An example of this we can see in collagen fiber. Basically, it needs to undergo hydroxylation, it needs to undergo cleavage, it needs to undergo acetylation for it to properly function. Now, if there is of course modification or mutation in the genome, then the proper collagen cannot be formed, and it will lead to several different diseases. Now, Finally, I'd like to basically summarize all the topic we have learned. From Viraj, we have learned what exactly is gene expression, why do we need gene expression. From Vijay, we have learned the different levels of gene expression. From Deosmita and Chandan and me, we have seen how exactly the different mechanisms act to complete the gene expression in eukaryotes. We know that gene regulation in eukaryote is a very complex process, more than that of prokaryotes, and any kind of dysregulation in this expression or regulation can lead to dysregulation, which will eventually lead to genetic disorders or cancers or autoimmune disorders and many things. This entire topic is incredibly vast, and our field of research is still ongoing, and eventually there will be many updates to it. So finally, I'd like to give you the bibliography. These are our sources. And finally, I'd like to thank you for listening to this presentation.
At this stage, you are expected to know if you can remember this very well. If you do not, please read it, number one. Because each can be a short question of any topic. And I must thank the entire team for presenting so nicely with so much academic content in a very abridged form. It is basically a summary of almost a 2-hour lecture. I mean, they have covered all aspects. I big applaud to all of you. Now, today, being a Friday, we can have an extra another 10-15 minutes time. But in other days, when the successive class is there, it is not possible. We have to put an emergency stop, just like RNA editing. Stop put on immediately. Well, okay. So that we do not want you to make. Please, go ahead.
A very hearty morning to my respected professors and my fellowship present over here. Today we are standing in front of you to speak on the topic tumor marker. The basic question that arises into our mind whenever we start up a new topic, and that is what? What is tumor marker? They are also called tumor index substances. They are the factors released from the tumor cells which could be detected in the blood. Indicates the presence of tumor in the body. Tumor markers are the substances produced by the normal cells or the cancer cells in response to the tumor cells. Useful purposes. For follow-up cancer and to monitor the effectiveness of the therapy, to facilitate the detection of cancer, presence of tumor cells, tumor markers suggest the diagnosis. For prognosis, serum level of the marker may indicate roughly the tumor. The precautions, the do's and the don'ts. Do's, use serial measurements, correlates with imagining findings, monitor rate of change, document baseline, combine multiple markers. The don'ts, diagnosis based on single value, use of screening in different assays of methods.
My name is Deepshika. I am roll number 37, and now we will proceed from what are the characters of tumor marker. The tumor marker should be specific for cancer, should be sensitive enough to detect it by various methods, should be higher in concentration than normal individuals. It should be tell us about what are the stages of cancer. Now we should know what are the classifications of tumor marker. The tumor marker are classified under two headings. Tumor marker which are derived or produced by tumor cells. It have three subheadings. A, oncofetal antigen which have example AFP or CEA. B, hormones which have example SCG and calcitonin. Enzymes which have example PSA or LDH. Host responsive and other produced by body tissue. Acute phase reactant have example ferritin or CPR, cell surface receptor, HER or estrogen receptor. The AFP stands for alpha fetal protein, CEA for carcinoembryogenic antigen, SCG for beta chain of chronic gonadotropin and calcitonin, PSA for prostate specific antigen, LDH for lactate dehydrogenase, ferritin, CPR for C-reactive protein, HER2 and estrogen receptor. Now we will proceed towards clinical importance of tumor marker. First one is alpha fetoprotein. Alpha fetoprotein is oncofetal antigen. It serves the function of albumin fetus, increase in circulation of patient with hepatocellular carcinoma and in pregnancy with fetal malformation of neural tube. Normal range in adult and non-pregnant female is less than 15 ng per liter. Normal value is 300 ng per liter is associated to cancer. Benign elevation, chronic hepatitis B and C usually less than 100 ng per ml. Cirrhosis from any cause, benign hepatic adenoma, pregnancy very high level and normal. We can see here the alpha-fetoprotein is associated with liver and testicular cancer.
Thank you, Deepshika. This is Dave, roll number 38. Now, moving forward with carcinoembryonic antigens, there is CEA. It is increased in colorectal cancers. Increased levels of CEA can also be seen in the breast, lung, gastric, ovarian, pancreatic, and uterine cancer. However, CEA is not completely specific for cancers because heavy smokers and some healthy individuals may also show the elevated levels of it. Therefore, CEA is mainly used for the monitoring treatment response and detecting the recurrence of the cancer. Moving to the next slide. That is beta chains of chorionic gonadotrophin HCG, synthesized by the normal syncytiotrophoblasts. Now, can anyone explain me what is syncytiotrophoblasts? Okay. Syncytiotrophoblasts is the outermost layer of the placenta that is in direct contact with the mother's blood. It's a glycoprotein. It consists of two subunits. The alpha subunit is similar with FSH, TSH and LH, while beta subunit is specific for HCG. Normal value is less than 20 international unit per liter for males and also for the non-pregnant females. A value of more than 10,000 international unit per liter indicates trophoblastic tumor. Now there is a graph, we will see it. This is a graph of a patient with the serum HCG level. This side we can see the HCG level before the treatment, and here we can see the patient's serum HCG level after the treatment. Moving to the next slide. That is cancer antigen 125. CA125 is a glycoprotein tumor marker that is primarily associated with ovarian cancer. Elevated levels may also be seen in cervical adenocarcinoma, endometrial carcinoma, gastrointestinal cancer, and the breast cancer. CA125 is widely used for the diagnosis, prognosis, and monitoring of ovarian cancer. Now moving forward with prostate-specific antigen that will be explained by my groupmate Dhruva. Thank you.
Good morning everyone, I am Dhruva, roll number 39. PSA, it is also a tumor marker. It stands for prostate-specific antigen. It is serine protease in nature and it is secreted by the prostatic epithelial cells. Its normal range is less than 4 nanogram per milliliter, but its range varies from age to age. Primary indication, when the level rises above 4 nanogram per milliliter, it is indicative of prostate cancer. But there are clinical limitations to it also. That is, always the elevated level of PSA does not always indicate the presence of prostate cancer. It can be also in cases of acute urinary tract infection. It can also indicate benign prostatic hyperplasia, and it also can be in cases of digital rectal examination. Even in patients of prostate cancer, there may be normal levels of PSA. Estrogen receptor, it is a nucleoprotein receptor found in breast. Elevated level of ER in tissue is used to determine whether a person is responsive to tamoxifen therapy or not. It binds to the receptor blocking the action of estrogen, and women who are positive to ER, who are negative to ER are at a greater risk of recurrence to breast cancer than those who are ER positive. Next comes the HER2/neu. HER2/neu stands for human epidermal growth factor receptor 2. It is also proteinaceous in nature. It stimulates the breast cancer cells to grow. These grow more aggressively than other breast cancer cells. As we can see in the picture, that is, the number of HER2/neu cells are very less in a normal breast cell, but they are aggressively huge in number in a breast cancer cell. HER2 positive cancer are more likely to respond to trastuzumab.
My name is Diksha and I am roll number 40. In this slide, we will compare between the different tumor markers, starting with PSA, which stands for prostatates specific antigen. Its normal range is less than 4 nanogram per milliliter. Its primary use is monitoring after the post-treatment, and it's mostly related to the prostate. It is age-adjusted, so it cannot be diagnostic alone. It is useful for the post-treatment. Next, CEA, which stands for carcinoembryonic antigen. Its normal range is less than 5 nanogram per milliliter, and its primary use is for the recurrence detection. Cancer type, it's colorectal and lung. Rising CA predicts recurrence 3 to 6 months early the clinical symptoms appear. Next is CA 125, and its normal range is 35 units per milliliter. Its primary use is again recurrence detection, and it is mostly related to the ovary. Next, clinical, it is elevated in the beginning condition, so it cannot be used for the screening purpose. Next is AFP, which stands for alpha phytoprotein, and its normal range is less than 10 to 20 nanogram per milliliter. It is primary use is diagnosis and monitoring. It is mostly related to hepatocellular carcinoma and the testiculars. Greater than 400 strongly suggests the hepatocellular carcinoma. 30 to 40% hepatocellular carcinoma has normal alpha fetoprotein. Next is CA199. Its normal range is less than 37 units per milliliter, and it is primarily used for the treatment purpose. It is mostly related with the pancreatic as well as the biliary cancers. Next is 5 to 10% Lewis negative, so it is not used for the screening purpose. Finally, to the conclusion, tumor markers are valuable tools in the cancer management, as tumor markers play a crucial role in the recurrence detection, prognosis, early detection, and they are not solely diagnostic and require complementing with other diagnostic tools such as biopsy, as well as the developing cancer genomics and the proteomics. Through molecular tools that is used, biomarkers are being developed, and it is used for the diagnosis, prognosis, and novel cancer therapy. So to conclude, that tumor markers are also being used for the clinical care. Thank you for your attention.
To say a few words, why tumor markers levels are so important. First and foremost, they are present in normal, slightly in very low concentration because of the continuous wear and tear. In cancer, basically, you see, when we develop zygote, that is basically highly undifferentiated cell. As the development proceeds, from the undifferentiated cell, the cells get differentiated. In cancer, yes, the reverse occurs. The cells gets from differentiated cell to undifferentiated cell. Okay. So then, basically, what happens? Whatever is available during the embryonic stage or the fetal stage, that stage is achieved, and that has a potential. That cells has a potential to replicate very fast. And depending on the type of cancer, the degree of development matters. Now, one point, the reason why it is because of the rapid proliferation of the cell, undifferentiated control, and because undifferentiated control cells doesn't have a normal genetic control, whatever we have been told during the eukaryotic translation regulation or gene regulation, I would say. Now, it has been told that there is, in one slide I have seen that there is a correlation with the imaging study. I repeat I am forced to remind you, this is a conception amongst all clinicians, and you will have a dilemma about that thing. All biochemical tests are the harbinger of all clinical manifestations. Basically, the problem occurs at the genetic level first. So if you do a genomic study, it will be detected at the very earliest stage. Then the proteomics. Once the gene is altered, the gene will be expressed abnormally, and the proteomic study of the cell will determine the first. Because of the altered protein, cell metabolism will be at fault, and the cell will start responding unnaturally. And at that stage, only biochemical, if the cell permeability is increased, that biomolecules will leak from the cell into the system and that will be detected. Now, when that stage is a little bit advanced, then the pathological stage will occur. So, morphological changes will occur and the disease will be detected if you make a histological section. But again, that stage will take some time to develop to make a size to cost radiologically, imaging study. So again, that stage will be there. After that stage, when it is quite advanced, then only the patient might develop symptom depending on many factors. So when the patient presents with symptoms, the disease is quite advanced. Okay, number one. Now, but at that stage, you will be getting that level, high level. Now you have started a treatment. Now, the success of the treatment will depend what type of modality you are taking, whether it is a chemotherapy or it is surgery or it is a radiotherapy. If you do a surgery, there will be a massive reduction of tissue immediately and there will be a drastic fall. If you do a chemotherapy, again it will take a little time, radiotherapy will also take a little time. But at one point of time, suppose the biomarker level is about 1 lakh. Now, if you make a surgery, it will drastically drop to 1 lakh. Its normal value, suppose it is less than 10. It will take a considerable amount of time to come down to normal. Even if it is coming down to normal, you can declare biochemically that the patient has normalized. Now, that patient requires monitoring. The earliest parameter which will be increased is the biochemical parameter. At that stage, though radiological cost will be bad, even PET-CT, which is commonly done in all the cancer patients, it requires a minimum size of 5 to 7 millimeter, and that is a considerably very big size microscopically. So until and unless that size is attained, it will not be available. So clinical correlation will not be always there. Remember, biochemical marker if it is abnormal, that indicates the cancer has started relapsing. Okay. Third point regarding the naming. So CA125 we have seen that naming is there. One cancer marker is 15-3. The CA125, what does the CA indicate? CA indicates cancer antigen. Cancer antigen is the main basic reason why it is CA. Carcinoembryonic antigen, CEA. Now, why 125? It was basically discovered in the year 1981 on monoclonal antibody. In fact, when I was doing my MD in 1988, I have done a hybridoma technology to develop monoclonal antibody. You have all seen microtiter plate. Basically, in that plate, a single clone of cell is developed and a monoclonal antibody is generated. Carcinoembryonic, this CA125 was identified using a monoclonal antibody that was developed at the 125th position of that microtiter plate. So, based on that position, that it was named. Similarly, CA1530, it is basically mucin protein. It was having a molecular weight of 150 to 300, and that was identified electrophoretically. Now, how to detect it? For detection of that thing, you require always an antibody, and all the immunoassay procedures are actually employed. So, in course of time, so initially it was told to be 150 to 300. Now, in course of time, it become 15 to 30. That is everything, every biochemical parameter has got a history of naming. So, that these are 3 points I want to say. Highlighting point most important is that it may not match with the imaging study, the best of imaging study also. Biochemical abnormality indicates that the patient has not recovered biochemically. Okay, it is not normal or earliest parameter. Question anyone can respond. We are having antibodies in our body, human body. We all are having, whether it is a monoclonal or a polyclonal. Basic concept I am asking you. First speaker one said second response. It is not second response, it is secondary response. In immunology, there are 2 responses. One is primary, one, you just get ready. Meanwhile, let me tell you. So, that is primary, means when you are encountering for the first time that antigen response, that is primary. And after some time, when you get a second exposure, that is called a secondary exposure, not second exposure. It is essentially second, but terminology is secondary. And can you tell us what antibody profile we have in our body? It is a monoclonal or polyclonal? And you have to justify. So this is the basic problem. This is the basic thing we want to know. See, I told you during immunology class, a monoclonal antibody, whenever triggered, a single clone of snail is proliferated, is a clonal expansion, and that particular antigen gives a monoclonal response. Now, we have encountered several antigens. We have taken several vaccines. So, vaccines themselves cause a polyclonal response. In addition, we suffered from infections. Many infections. All the infections generated a monoclonal type of response. So basically the immunoglobulins which we are having in our system and any animal is having is polyclonal in nature. And that is the reason why there is a need for development of hybrid technology to identify, to make synthetically a huge amount of monoclonal antibody for research purposes and for therapeutic purposes. And monoclonal antibodies are being used extensively in cancer treatment to target cell, so that cancer cell which are having a receptor will be tagged to that cancer drug and it will have a targeted drug. Okay?
Professors and my dear friends, I am Farhan Anjum, and along with my group members Divyanshu, Hayat, Gauri and Fatma will be presenting on iron metabolism. I will briefly introduce the introduction and distribution and absorption of iron. Iron is an essential trace element required for numerous biological functions in our human body. It's required in very small amounts. Its main function is in oxygen transport through hemoglobin. However, it has other main functions as well, such as cellular respiration, DNA synthesis, and enzymatic reactions. An adult male requires 8 to 10 milligram of per day of iron, whereas in adult females it's 15 to 18 milligram per day. The requirement is more in females because some amount of iron is lost through menstruation. Also, need for iron is increased during lactation and pregnancy. Iron can be found in dietary sources such as fish, meat, green leafy vegetables, cereals, pulses, meat sources and vegetable sources. We'll go to distribution of iron. The human body contains approximately 3 to 5 gram of iron. Most of the iron is found in the form of hemoglobin in our body, which accounts for almost 75%. The rest is in liver, bone marrow and muscles. As I've said, 60 to 70% is found in hemoglobin, since it is the main function in oxygen transport. 20 to 30%, around 20 to 30% is found in the form of ferritin and hemosiderin. It's found mainly in liver, bone marrow and spleen. Liver, bone marrow is 20 to 30% in the form of ferritin and hemosiderin. 5 to 10% is found in muscles in the form of myoglobin. It is also found in small amounts in transferrin bound iron and enzymes and cytochromes. Absorption of iron mainly occurs in the duodenum and the upper jejunum region of the small intestine. There are mainly two forms of dietary iron, heme iron and non-heme iron. Heme iron is found in animal sources, fish, meat and poultry. They are absorbed more easily by our body in comparison to non-heme iron. Non-heme iron is present in cereals and vegetables. They are absorbed less efficiently than heme iron. Thank you.
Hello, my name is Fatima Malika, roll number 43. I will be continuing from mechanism of iron absorption. Ferric iron is reduced to ferrous iron by gastric acid and vitamin C. Fe2 plus is absorbed in duodenum and upper part of jejunum through DMT1, divalent metal transporter 1. Inside enterocyte, iron is either stored as ferritin or transported into blood via ferroportin. Iron is oxidized back to Fe3 plus by hephaestin. Fe3 plus bind to transferrin in plasma and transported to tissue.
Factors influencing iron absorption, only Fe2 plus form is absorbed, Fe3 plus form is not absorbed. Factors increasing iron absorption, vitamin C, gastric acid, heme iron, iron deficiency. Ferric ions are reduced with the help of these and thus will help favor iron absorption. Factors decreasing iron absorption are phylates, oxalates and some minerals like calcium, lead, copper, phosphates. Then we go to transport of iron. Iron is absorbed from intestine, enters the blood and transported into plasma, bound to transferrin. Transferrin is synthesized in the liver and it can bind to 2 ferric ion. It carries iron to bone marrow for synthesis of hemoglobin synthesis, liver or spleen for storage or other tissue for metabolic functions. Cell take up transferrin bound iron through transferrin receptor on their surface. Inside cell, iron is released and utilized and stored as ferritin. Thank you.
Good morning, everyone. I, Gauri Gupta, roll number 44, will start from storage of iron. Iron is mainly stored in liver, spleen, bone marrow, and skeletal muscles, and it is mainly storage form of ferritin. It is water-soluble protein complex found in liver, spleen, and bone marrow. And hemosiderin is an insoluble storage form of iron, mainly in the macrophages of liver, spleen, and bone marrow, formed when iron stored are excessive. And next is regulation of iron metabolism. Iron metabolism is tightly regulated to prevent both toxicity and deficiency. It is covered at 2 levels, systematically by liver secreted hormone hepcidin, cellularly the iron regulatory protein iron responsive elements IRP/IRE system, maintaining homeostasis in the absence of an active excretory pathway. Circulating iron metabolism. Iron is absorbed mainly through duodenum by HCP1 and DMT, and it is transported to the iron, and the iron is transported in blood. It is transported in blood by the help of ferroportin, and in blood it binds with transferrin, and then it forms transferrin iron complex, and then it is transported to the bone marrow and then it is stored in liver as form of in the form of ferritin. And cellular iron metabolism, transferrin bonded iron is received in transferrin receptors and it is transported to lysosome. Then it is transported into the cytoplasm, and in the mitochondria it helps in export and utilization and storage.
Good morning to all of you, my dear fellow colleagues and respected professors. I am Divyanshu, roll number 41. I am carrying forward the regulation of iron metabolism. The systemic regulation, I'm going to first talk about systemic regulation. The hepcidin ferroportin axis system, iron balance is dictated by the amount of iron absorbed from the diet and the amount recycled from the old RBC cells. The importance of hepcidin. Hepcidin is produced by hepatocyte cell, the peptide hormone master regulator of iron. The primary functions of hepcidin are to control the plasma iron level by binding to the ferroportin and further intestinal degradation, so that the body's sole iron exporter. Ferroportin degradation. When ferroportin is degraded, iron remains trapped inside the cells, reducing the iron entering the bloodstream. The second regulation is a cellular type of regulation. The IRP or IRE system individual cells that are responsible for management of internal requirements to meet the metabolic demands, for example the DNA synthesis, mitochondrial function through the post-transcriptional control. Mechanism: iron regulatory proteins like IRPs bind to specific stem-like structure called iron responsive element, which are located on mRNA. The basic functions of iron. The first primary function of iron is oxygen transport and storage. Iron is a core component of hemoglobin and RBC, which are responsible for carrying oxygen from lung to rest of the body, and myoglobin, which stores oxygen in the muscle tissue. The second function is energy production. It serves as a vital cofactor for enzymes in mitochondrial, respiratory cytochromes, driving cellular energy and ATP production. The third function is synthesis of DNA. The iron-dependent enzymes are critical for the replication and repairment of the DNA. The fourth function is cellular metabolism. The iron acts as an electron donor, acceptor, and catalyzing redox reaction for various metabolic processes. The fifth function is immunity and cognitive function. It supports production of WBC and necessary for the immunological function and myelination of brain.
Good morning, everyone. Now that we have learned the importance of iron, we'll be moving on to the clinical aspect of iron. So first is iron deficiency anemia. It is a condition in which hemoglobin synthesis is reduced due to the insufficient iron, resulting in decreased oxygen carrying capacity. It is the most common nutritional deficiency, which affects up to 30% of the worldwide population and affects about 70% of the Indian population, and 85% of the pregnant women suffer from iron deficiency anemia. Next, we will be moving on to the causes of iron deficiency. First is nutritional deficiency of iron, hookworm infestation, repeated pregnancy, chronic blood loss, nephrosis, lack of absorption, and lead poisoning. Next, we'll move on to the acute iron toxicity. It occurs when there is a large amount of iron is ingested accidentally or intentionally. If more than 50 milligram of elemental iron is ingested, then it results in toxicity, and if more than 100 milligram is ingested, then severe poisoning occurs, which will even lead to death. Symptoms include nausea, vomiting, diarrhea, abdominal pain, and dehydration. Next, we'll move on to another clinical symptom called hemochromatosis. It occurs when there is excess deposition of iron in tissues without significant tissue damage. It deposits mainly liver, spleen, and bone marrow. Causes are repeated blood transfusions, thalassemia major, and hemophilia. Features are increased blood iron stores and usually minimal organ dysfunction. There is minimal organ dysfunction initially. Next is hemochromatosis. It occurs when there is an excessive absorption and accumulation of iron in the body. In human body, there is 3 to 4 gram of iron, but in hemochromatosis, we can see a significant rise up to 25 to 30 milligram. In this, iron may be deposited in liver, pancreas, heart, skin, and endocrine glands. Clinical features include liver enlargement, liver cirrhosis, heart failure, or arrhythmias, joint pain, and weaknesses. Next is bronze diabetes. This is basically advanced hemochromatosis. In this, you can observe a bronze pigmentation on the patient and increased melanin production. The classic triad of hemochromatosis. In this, you can observe cirrhosis of liver, diabetes mellitus, and bronze skin pigmentation. Next, we'll move on to some more features of iron deficiency. First is you can observe in patients that when you don't have enough healthy blood cells, a patient can be fatigued, can feel weak due to less oxygenated blood transfer in the body. Next is iron is very important for synthesis of neurotransmitter. In this, you can see people with iron deficiency leading to lower than normal duration of focus. Next, not having enough iron deprives your muscles of their ability to recover properly. apathy towards anything and everything, including friends, family, and work. Brittle nails can be seen due to low iron levels, and there is a reduced oxygen delivery to the renal matrix. And next, you can see washed out appearance due to reduced blood flow and decreased number of RBC.
On hepcidin, because that is the question what I have said last time, and you have not elaborated. That is one important question. You must know why you have not elaborated properly. Hepcidin part. You just go back to the slide. Back to the slide. You just see. You have written that this peptide hormone acts as a master regulator of iron. It's a very, famous statement. A most well appropriate statement. Hepcidin regulates. How? One way is mucosal block theory, you have not written at all. Second is regulation by macrophage.